Welcome to The Summary, a podcast from Mary Free Bed, where we explore physical medicine and rehabilitation, one topic at a time. Together, we will gain insights, discover innovations, and deep dive into the latest developments in the field.
So, Yunna, why did we decide to talk about cancer rehab?
So, as you know, cancer rehab is very near and dear to my heart. And when I went through my stage 3 rectal cancer, one thing I did not realize is not just the chemo and surgery process, how difficult that was going to be. I kind of feel like I knew that, we all know that. However, the recovery process was actually somewhat even harder than the actual diagnosis and therapy. So once I was in remission and coming back to work, that's when the real struggle began for me. And I started thinking, oh my gosh, what if I had my own cancer rehab doctor back then? How would that have made it easier? I really do believe, because I felt like I was almost my own cancer rehab, teaching myself how to do my own bowel programs because I no longer had a rectum or things like that. So that's why I really wanted to talk about this topic. And that's how we have Dr. Sean Smith. Thanks so much for coming on the show.
Thanks for having me. Yeah, no, I'm really happy to be here and hopefully get more of the word out about this specialty in this field.
So, Sean, one of the big questions we had is what unique expertise and values do physiatrists who are specialized in cancer rehab bring that our general physiatrist could learn from or that we don't bring?
Sure. Well, the one answer is that general physiatrists or physiatrists who specialize in brain injury medicine and so on can apply all of their skill set to the cancer population. What I think sets apart some of the cancer rehabilitation physiatrists, cancer rehab medicine doctors, is a few things. One is we have to be up to date on the latest treatment, toxicities from the treatment, and sort of be ready for any sort of patient to come through the door, whether it's, someone with active cancer or not, and if the cancer is spread and that sort of thing. The other is we do have specialized procedures that we do that aren't entirely unique to cancer rehabilitation, but especially in PM&R often are, and, that might be, botulinum toxin to the pterygoid muscles on the face, that type of thing that maybe you'll see if you do oromandibular dystonia care, but generally I think is not a core part of PM&R. But I think one of the most important aspects of this we bring is this sort of bigger picture of what a patient has gone through or is going through, and how can we set proper goals for them, and help them meet that. Is it somebody who is a long-term survivor, but their radiation fibrosis is going to be chronic and something they're going to have to deal with? Are they a survivor and they have, some focal pain we can alleviate pretty quickly? Or do they have a diagnosis that's expected to be fatal? And how can we balance kind of what normally I think in rehab we think about, which is, an event happened and we're going to, optimize your function and set you up to, achieve goals that, might be feasible. In this case, sometimes we have a limited window for patients whose disease is advanced. And so we can sit down and talk with a patient and set some functional goals within that framework. And I think working with cancer population helps us to sort of be able to have that bird's eye view and address a really important part of quality of life that other specialties kind of can't.
Yeah, I think you put that well. It makes me think of if you see a lot of patients with brain injury or stroke, you get a feel for what kind of recovery they're going to have. And in your case, that's much more complicated when you've got chemo and radiation and fatigue and things like that. So just having a good feel for what these patients are going through and what their recovery might be, I see that in itself being important for a physiatrist who's specializing in cancer.
It's really dynamic. Patients can change on a dime. And someone you saw 2-3 months ago might be totally different, good or not good, and so you have to be ready for for that. It's less predictable, and so I think this specialization helps us sort of navigate those unpredictable waters.
Mm-hmm. You kind of touched on terminal cancer diagnosis, and I can see that being one of the almost most complex areas where your goals are so different from each person to person. Well, where does cancer physiatry, cancer rehab meet these terminal patients with terminal diagnoses?
Yeah, so good question. Even within this population, there are so many branches of it, right? So what was considered terminal 20 years ago is not necessarily terminal. So we're seeing cures for melanoma that's spread to the brain, which is, if you had a time machine and could tell somebody in 1999 that happened, they would, they'd probably be surprised at your time machine, but they would be also very surprised at this revelation. We have diseases like multiple myeloma where there's technically no cure, but there's always new drugs coming down the line. And from when I was in medical school and told, the prognosis is 5 years or less and it's grim and this and that, and now we have patients living indefinitely. So terminal has changed a lot. People with brain and bone metastases are living longer. And in fact, their priorities are now shifting. So historically, the medical field has said, well, let's get you comfortable. Maybe we can give you some chemotherapy or whatever to prolong things, but let's get you into palliative care. Let's get you a bunch of pain medicine, et cetera. You rest and sit down. Now, patients, even with, advanced disease, want to continue working, continue, spending time with their family, and that all is function. And so we're seeing a lot of patients come to our clinic. About 40% at University of Michigan in our cancer rehabilitation clinic are people with what we would consider advanced disease or, potentially, probably eventually fatal. But I have patients who I've been following for over a decade, with these prognoses that a decade ago, it wasn't thought that they would have this. So it's been, again, it's that bit of unknown, but in a way you can, see, as long as you're realistic, you can sort of see a path forward for some of these. Now, I will say there are other diagnoses, glioblastoma, pancreatic, that type of thing, where the prognosis has not changed fundamentally over, the past couple of decades. And those are a little more predictable and, in that sense, easier to sort of set goals and prioritize. But, it's really a wide open field right now in a good way.
Can you tell us a little bit about your program there at Michigan, the MCORE program, and how you might do things differently than other programs?
Yeah, so we have a robust outpatient and inpatient cancer rehabilitation program. On the inpatient side, where patients tend to be sicker and or they have some kind of neurologic deficit, either a primary or secondary brain tumor or a spinal cord injury from malignant compression. Those patients, like at Mary Free Bed and others, I presume go to inpatient rehabilitation as long as they have goals and they can participate in that sort of thing. We have a program called MCORE that you pointed out. It stands for Michigan Comprehensive Oncology Rehabilitation, the R and the E are together. And we developed that program to serve and fill a gap. And what we found was patients would be admitted to the hospital with, let's say, acute leukemia. And they would get weeks and weeks of chemotherapy, which would fatigue them, which might cause diarrhea, and then they're in bed for longer. They might be off the floor for tests, and so they would see physical therapy maybe a few times a week, standard of care. But if they miss them, and a lot of these patients' function would really just dwindle and decline. And we were seeing patients going to SNFs, subacute rehabilitation facilities, which are really not usually a great place for patients who are very weak, immunocompromised, medically complicated. So we developed this program, the MCORE program, to sort of increase the dose, if you will, of acute care, physical and occupational therapy, and have a physiatrist start to follow them early on in their course. And what we found is, number one, we're getting a lot more referrals, which is good because that meant that probably we were missing patients before. But two is that we're seeing less patients go to these SNFs. they're either going to inpatient or home, and then they've already met their physiatrist. They can follow up with us after that. So it's a connection we make early on that's really helped. On the outpatient side of things, we have a really robust lymphedema therapy program where we have therapists who specialize in head and neck and facial disorders, but of course limb lymphedema as well, with all sorts of modalities and tools. We have wonderful physical therapists who have continuing education and scheduled regular educational meetings to get everybody sort of comfortable treating these patients, because with the volume we have, we can't send everybody to one person who has this interest in cancer rehabilitation. It takes a village. So we've developed an educational system to bring everybody sort of on board, able to identify, okay, this person has bone metastases. These are things I should think about and look for. And then, of course, we have the physicians. We have 2 plus a fellow every year that see patients who are maybe more medically complicated. Maybe they still have pain or restriction or weakness despite trying therapy, or maybe they need an interventional procedure, and that's where we come in as well. And it's a really good, harmonious program. I'll say one last thing is one of our secret weapons is we have neuropsychologists, rehabilitation psychologists who subspecialize in this too. And so that can get people, who have chronic fatigue or a hard time adjusting into one of our programs. We have different ones for acceptance and commitment. We have, coping skills, that type of thing. Or we can do neuropsychological testing for cognitive impairment after chemotherapy. And someone can, credibly tell them this is their focus and this is what's going on in their life. And it's just a really great multidisciplinary, robust program. I'm proud to be part of it.
Yeah, can you tell us just a little bit about what it's like to set up a program for someone who maybe doesn't have that in their place?
Yeah, this is a question I get asked a lot, and honestly is probably the most important part of cancer rehabilitation, because we need to have more programs. Patients are desperate for access, and every location is different. And so this isn't a one-size-fits-all thing. When I started, my chair said, okay, we've tried cancer rehab a few times at Michigan. You can try it. If not, we have general spine patients you can see, and I was going to do general inpatient as well. I said, sure. Where the deal was, as I built up the cancer clinic, I would do less spine clinics. There was 1 physical therapist and 2 occupational therapists who specialize in lymphedema, and they're wonderful and invaluable. But the good news is that within a year and a half, I was out of all my spine clinics because the cancer rehabilitation clinics were so full. Not just because of me, but because of patient volume and word, we started hiring lots of therapists who specialize in this, including lymphedema, and I think we're up to 7 or 8 now. And the key to this, and what can challenge some, but I think also helps others, is that you really have to sell the value of physiatry, especially physiatry, to the stakeholders, and that means medical oncologists, surgeons, radiation oncologists, and when I say surgeons, I mean ortho, plastic surgery, general surgery, breast surgery, everyone on down, and somewhat to administrators. The thing I consistently hear, I would say 9 out of 10 times when people start a program, is that they are welcomed with open arms, and the reception is, thank goodness you're here. Where have you been all this time? There's not an oncologist out there, or if they are, they're alone. There's not one out there that says, no, I don't think my patients need to function better. I think we got this. There are some, I think people maybe nearing retirement who might say, well, we have a physical therapist. What do we need you for? But that's where I think you have to really reflect on what physiatry is. Forget cancer physiatry. Forget brain injury medicine, all that. Like, what value do we bring? Okay. And so you have to distinguish yourself from physical therapy. I'm not a physical therapist. They do things I don't know how to do, and I do things they don't know how to do. But what we can do is we can manage symptoms, We can improve function. Don't say quality of life. Everyone hates quality of life. It means nothing, right? Don't say quality of life. Say I can improve their function, or you can speak their language and say performance status. I like to give examples that are really easy to wrap their head around. I don't like to be vague and say we can work on people getting stronger. That what does that mean, right? Even though we all know, the rehab people listening to this know what that means. That's really nebulous. So I might give examples of this is a procedure I can do for post-mastectomy pain. This is something we can do for aromatase inhibitor arthralgias. This is how I assess somebody for radiation fibrosis syndrome. I can offload those patients from you. I can order and interpret diagnostic tests, including MRIs, EMGs, all that, which are something that physical therapists or occupational therapists or whoever can't. I can prescribe medications and I can coordinate all this for you. And they say, thank goodness. But once you get them in the door for the post-mastectomy pain or whatever, I found that it was really quick and easy to get the word out as far as I could also diagnose and treat mild cognitive impairment or that deconditioning or peripheral neuropathy that, before I was here, they just assumed had to go to neurology, But when you can talk about the functional implications of some of these things, it's a lot easy. The one challenge is that it's a lot of work and you have to sort of water your garden, if that makes sense. So when I started, I did a road show. I went to breast cancer. I went to palliative care. I went to plastic surgery, ortho, blah, blah, blah. I showed my face a lot. I gave talks. I gave grand rounds. I, showed up to their tumor boards, at least the ones that were maybe relevant, like sarcoma or brain tumor. Those are the ones that are, really there's a, for one, having a physiatrist in the room might change the decision making, but there's functional talk of the treatment there as opposed to, pancreatic or something. And it sort of, I made it known that I wanted to be one of the team, and they were happy to have me. You're not going to get anywhere, I don't think, if you are very general or you get up there and say, hey, you should send me your patients when, they think that everything's being treated okay as is with status quo. And if you run into trouble, there's national guidelines that, have been written that say you need rehabilitation. There's some that specifically recommend PM&R to be involved in XYZ, and that really helps. We're trying to get more physiatrists on these guideline writing committees, and we've gotten some, and to sort of reduce the threshold that you have to clear, so to speak, to get the referrals. But I think it really takes somebody to put themselves out there, communicate well, make a PowerPoint that doesn't have 50 words on a slide, right? Like basic stuff there's nothing special about cancer rehab, but you really have to dig deep and think about how you're different than therapists and what value you bring and why this patient should see a 7th or 8th doctor and why it's worth their time.
Yeah, great points. I think especially because I see a lot of doctors who basically come by and say, send me your patients. But, tell them what you have to offer their patients and how you're going to take some of the burden off the physicians and overall provide better care for those patients.
Yeah, it's been like advocacy, right? It's like advocacy for your patients, yourself, but also for what you're doing is for the entire specialty, not just cancer rehab, but the whole world of rehab. So that's really amazing. Thank you for all the hard work you've put in.
I think there's such a dire need. There are far more cancer survivors with physical or cognitive impairments or disability than there are people with a traumatic brain injury or spinal cord injury and all that. That's not to say we shouldn't emphasize that, but it's to say we need all hands on deck to meet this need. And, it's not going to be filled by another specialty. So patients are going to go without it. And so I encourage all of our trainees and anyone I work with to, become an advocate, nationally, regionally, whatever you can, to get the word out. Because I think it is something where we all have to be kind of rowing the boat together.
Mm-hmm. Yeah. One thing earlier you talked about was accessibility. And you told us how your clinic grew so much that all of you kind of came out of spinal cord injury care and then you went full on cancer rehab care. What other ways, I know you have some telemedicine clinic that you're doing too as that part of the MCORE programs. What are some adjunctive ways that you've used to increase accessibility for our patients?
That's a good question. You know, some of it is elbow grease and overbooking and everything. Telemedicine's part of it. You know, with the acute care MCORE program, bringing the rehab to the patient rather than, you know, waiting for them to come to your clinic. Those types of strategies and trying to grow quite frankly, you know, and you know, having multiple faculty members who could do this. You know, it's tough. You know, I would love to expand even more, but you also need access. I think that's a challenge too. I mean, with anything, patients want to be seen quickly, but in cancer, they're used to being seen really quickly when there's a new symptom or any problem. Even if it's, you know, they have chronic back pain and you're seeing them for that, you kind of have to see them pretty quick. So it takes some finesse with the scheduling, and I don't have a great answer for that.
I'm hearing a little bit more about prehabilitation. Can you talk to us about that in general and specifically in the cancer world, how that applies?
Yeah, this prehabilitation is it's a well discussed and well liked topic, you know, among rehabilitation providers, including PM&R physicians. And the idea is that the stronger you make somebody going into an event or something that may lessen their function, the easier time they'll have during that treatment or during their recovery. And so there's been studies largely in surgical populations for cancer, so colorectal, bladder, lung, that showed that if people exercise before surgery, they end up, you know, recovering quicker, less length of stay in the hospital, they walk longer. A lot of the research has been in if people walk more before surgery, they walk more after surgery and quicker. There's been some breakthroughs, like with one lung cancer study found that patients who were too weak to have surgery to resect their lung cancer after prehabilitation were statistically likely to be able to then get surgery, which could be curative, which is really great. Mm-hmm. A lot of it, though, again, is if you walk during your chemotherapy for colorectal cancer, you're going to walk more quickly. What we need, I think, is this next level of can we empower patients with this is a home exercise regimen, this is what you do in like a 1 or 2 time visit, because they've researched, like I said, colorectal cancer where patients might be on chemotherapy for months before surgery. Mm-hmm. Lung cancer where maybe they can't have the surgery, so you have this time to prehabilitate. Where I struggle is in 2 ways. One is I'm not so sure a physiatrist needs to see a patient to say, go walk, right? That's something a nurse, physical therapist, exercise physiologist, lots of people can do and do as well as I can. So it's cheaper and easier and faster for patients to get into those specialties. I do think there's a value in PM&R seeing some of these patients, because the other issue with prehab for me is most of these cancers, a lot of them, the treatment happens really quick. You're not going to sit and watch somebody with breast cancer with a tumor that needs to be taken out for 6 weeks while they walk more, right? That makes no sense. Brain tumor, etc. So is there a way to sort of target a program, a regimen you can give someone? This is what you do for the 4 days before surgery. This is what you do day 1 post-op. This, and this. Set up a visit maybe with a PM&R physician. Okay, you have nerve pain and you can't position your arm for radiation. Let's block that. You know, things that are actionable, but don't require this really long length of time. I think that's the next frontier, because we pretty well solved, you know, moving is good. We need to, I think, take that next step.
When you said that, it almost reminded me of when, you know, right before surgery or anything like that, how they call you and say, like, don't forget to shower with HiPoCleanse. Don't forget to, like, wash yourself with all these specialty soaps and pick it up. And it kind of reminded me of, yeah, even that short reminder, like here are the functions I want you to do, these are the exercises I want you to do before your surgery, could be as simple and easy as that on the lighter end too. What about what does your referral process look like? How early on are you getting to see your patients who have these new or old diagnoses of cancers?
That's a good question, and it varies. I mean, we see people just diagnosed to people, nearing the end of life, or people who've been, I had a patient who had her radiation in 1969. We see it all, and there's not one answer for when should a patient see someone, but I think as soon as an impairment or a functional decline has been identified that we might be able to treat, so neurologic, musculoskeletal, cognitive especially, I think that's when the referral should be placed. And we try to get people in pretty quick, depending on the time of year or what have you. Our wait time might be, yes, we could see you within 2 weeks, or no, it's going to take 3 months. But, at least here in Michigan, the surgeons or whoever are good about sending me, a urgent, inbox message with the red exclamation mark saying, can you see, Mrs. Jones, she's got this and we need to do this before, or one of the orthopedic surgeons will say, I'm planning, I am going to 3D print this person a new hip and we're going to take out his sarcoma. Can you please see them before, 2 weeks, because you have to talk to them about function and rehab afterwards. So we get those kind of one-offs, which are really helpful too. And I'm thankful that our referring colleagues tell us about those patients who should be seen quicker. Sorry for all the ambient noise. The construction.
No, I actually really like it because it makes me feel like, that rumbling sound behind that's going on. It makes me feel like, cancer rehab is a rumbling topic, right? It's so important. So I feel like it's like emphasizing all of that too.
Yes, it's under construction, but my goodness, it's come a long way.
Sean, you had mentioned earlier different kinds of procedures that you guys do, and I think a lot of them I may not be familiar with, including Botox to the pterygoids. Can you talk a little bit about some of the procedures you do in this field?
Yeah, for one, any sort of physiatric procedure could be applied to a cancer patient. We might see someone with knee arthritis and a cortisone injection or hyaluronic acid might be indicated, whatever. And so we do those types of things for general PM&R issues, even if it's not related to cancer. The more unique things tend to be a lot of times in our breast cancer or head and neck cancer survivors. So in breast cancer, a big pain generator are nerve endings along the rib cage, this neuropathic pain that's been characterized since the 70s. But what we've found is that a lot of these patients have really swollen neuromas. It's really close to the skin. These are cutaneous intercostal nerves that are painful whenever you put a bra on or someone hugs you, or if you have a seroma or some complication of surgery, it can be worse. So for that, we might do a nerve block, and if that works temporarily but fizzles out, our plastic surgeons will operate on it. We do botulinum toxin to the pec major, pec minor, scalenes. We see oromandibular dystonia and trismus where the jaw can't open. And we'll use botulinum toxin for that too, to try and get the jaw opening better, reduce pain when they chew, improve jaw alignment. Because if the lateral pterygoid is affected, it's going to pull you to one side and that can cause pain. Any cancer that affects the mandibular nerve can hit the pterygoids, the masseter, the anterior digastric, all these muscles that can clench the jaw or make it uncomfortable to chew. And those are the main things. I would say that the other, not just learning those procedures, the other part of this is when should you apply them. So, we have patients on, immune checkpoint inhibitor therapy. And depending how long they've been on that and how well controlled their disease is, you might not want to give a steroid, which would suppress the immune system, whereas the checkpoint inhibitor therapy removes a checkpoint that stops the immune system from killing the tumor. So you have to balance that. There are other, chemotherapies for renal cell cancer that, inhibit VEGF, vascular endothelial growth factor, or, bevacizumab, commonly called Avastin, is one used especially for cerebral edema. Those increase the risk of bleeding. So there's new drugs that we're not going to learn in residency that is helpful for the cancer rehab physiatrist to know. And of course, we see neutropenia, thrombocytopenia, that sort of thing that we have to balance.
A lot of patients move on to different types of chemotherapies as well, I imagine. So in that case, are you constantly talking to the oncologist and making sure, like, okay, here are the things that I need to look for, or before this, let's make sure these things are in check prior to initiating a new treatment?
As we do this more, if we see certain chemos and their blood counts are where they should be, we don't need to. I always, if they're on a checkpoint inhibitor and I really think the patient needs a steroid injection, I will ask, and say, hey, what do is this okay? And 9 times out of 10 or more, it is, right? And then with things like bevacizumab, the half-life is, around 20 days, give or take, or maybe 18 days. And so they get the infusions every 21 days. So you can time an injection, right before the infusion or something to minimize the risk. So there are ways around it. And sometimes I do, talk with the oncologist. It all just depends on what they're on.
Mm-hmm. As you're pioneering this field of cancer rehab, what are some trends or changes you've seen in the field of cancer rehab?
Great question.
And what do you see down the road?
Yeah.
Ooh, this is a really good question. I have to think. The biggest change is there's so much more of us, and you go to the AAPM&R conference, and it's just this wonderful meeting of PM&R physicians passionate about this in a tight knit group. And this year's ASCO, American Society of Clinical Oncology, there's several physiatrists going, which is unheard of, and so that I think is really special. I see the field moving in a few ways. I see people leaning on procedures a lot, which is not a bad thing because, again, it's a really easy selling point when you're building a program, and it does add value. But I do always tell our fellows or anyone who will listen to me that that's a part of this. There's the bigger part is goal setting is not procedural. I'm seeing that more. Where this goes, I really don't know. I think what we have to do is we have to expand our evidence base to justify what we're doing and to get more referrals in the door. And how we do that is one conversation, but what we have to do is we need more research. And that sounds, like, oh, we always say that if you read any sort of article in the PM&R journal, the last paragraphs, more research is needed. Yeah. But, oncologists are used to phase 3 randomized controlled trials to make any change, right? They need 6 sites to have given this drug, and they need to see the hazard ratio. They need to see everything combed over a fine-tooth comb before they're saying, okay, we're going to change this. Or the folks who write the guidelines say, okay, we're going to put this in the guidelines. We don't have that. I'm unaware of any phase 3 PM&R based trial. We have some phase 1 trials. And just to back up for folks who might not know, phase 1 or even 2 trials are usually a randomized trial done at like one location. So if I wanted to say, we're going to put botulinum toxin in the pterygoids at Michigan, randomize it, that's a phase 1 or 2 trial, depending how many people are enrolled. And then phase 3 is where you get outside and to multiple sites so that they could say, okay, this worked, but it wasn't because the water in Grand Rapids or Ann Arbor was better. It's because this actually works. And we need that. I'm seeing more cancer physiatrists interested in this. Whether or not that bears out with, grants and everything like that, I don't know. But I think that's where we need to go. And I think where it's going to is we're just integrating more with cancer centers and, large oncology groups. So I could see more private practice cancer rehab physiatrists joining these big hospital groups full of hematologists, oncologists, radiation oncologists. And I think that'd be wonderful out in the community. And, probably every major cancer center will have a physiatrist in the next 10 years for sure. I mean, we're almost there, to be honest, depending how you identify or define major. And then we're just going to have to go where the wind blows, where if all of a sudden this one cancer is cured or people are living longer with this, but there's a toxicity, we're going to shift to there. I know this is a long answer, but I also think that toxicities and surgeries are getting less morbid. As an example, here at Michigan, at least, if someone who has a mastectomy and wants implant breast reconstruction, now they put the implant on top of the pectoralis muscle, called a pre-pec implant. Before it was sub-pec behind it, which would stretch it, and that's where we saw so much dystonia, tightness, spasm. We're seeing that a lot less now. So I'm doing a lot less botulinum toxin, but I'm as busy as ever. And so I think you got to be able to adapt to what changes. And the North Star needs to be, we're physiatrists. We are prepared for anyone who walks through that door. If they have a brain problem, if they have post-mastectomy pain, if they have spasticity, whatever, we got this. And you have to be ready for that.
I want to echo that. That was so eloquently said. We're physiatrists. We are prepared to deal with anybody or any condition that walks through that door. That is such a true statement.
Help those patients any way we can.
Mm-hmm. Absolutely.
Yeah, I guess I wonder, first of all, how many fellowships are there? And for residents listening, we learn basic rehab concepts in residency, and why is a cancer rehab fellowship important?
Good question. So when I went into the field, I realized I wanted to do cancer rehabilitation in July of my 4th year of residency, which was too late to apply to one of 2 fellowship programs that existed then, because they kept moving the application date earlier and earlier, I think, to compete with each other. And so I wish I could have had a fellowship. There are some folks that say you don't need one. I think to be a really well-rounded cancer rehab physiatrist and to be able to sit at the table arm in arm with all the oncologists, with the best and brightest surgeons, et cetera, I think it really lowers that threshold and energy startup, or whatever analogy you want to use, to get you there at that level, and helping you credibly speak to patients or providers rather, to get the patients in the door. I also think, going to a different location than your residency and getting 12 months of repetition in is invaluable as well. Our residents don't see these sarcoma patients with 3D printed hips, or a lot of these post-mastectomy pain procedures. And they get more cancer rehab, I think, than most residency programs get. So if you really want to be a leader in the field, really want to make this your career, I think a fellowship is really helpful. I think there's something like 12 fellowship programs. I could be wrong. There's X fellowship programs and X plus 2 spots, because 2 fellowship programs have 2 fellows a year. They don't always fill. In fact, I don't think there's going to be 14 or whatever applicants this year. And so I always tell the applicants, you have the leverage. You need to go to a program that is well-rounded, that will give you exposure to a variety of cancer types, right? Some programs, not necessarily fellowships, they might be 75% breast cancer. And so if you go there and you go to a different job where you're seeing a lot of head and neck or sarcoma, it might be harder. So go somewhere where you get variety, where you're not just maybe only doing clinic or only inpatient, have a mix. If you're interested in procedures, ask about what type of procedures they teach you on, because that's, again, something that's unique to our specialty. And, we don't have an official match, but we go through the NRMP, where it is, as official as you could get. I would say go through there. There are some programs that might try to get you to sign on the dotted line outside of there, and you don't have to. They want you more than you want them, probably, right? So, really advocate for yourself and try to find the right place for you. Interviews are virtual now, so it's never been easier to really get to know a program. Yeah.
I've learned a ton. Thank you so much, Sean. It's been nice to get to know you and learn a lot about cancer rehab.
Yeah, absolutely. And couldn't thank you more. As a person who's been through cancer, how I can't imagine how amazing it would have been to have you on my team, right? But I'm glad I have you on our PM&R team all together.
Yeah, we're all in this together. If I can emphasize one thing I said, it's that we need the whole nationwide community of cancer physiatrists. And if someone out there is listening and thinking of getting involved, either they're in their career already and want to see more cancer patients, or they're in training or considering PM&R, come to our virtual meetings, or the AAPM&R conference especially, and you'll be welcomed with open arms into a really good community that will support you however much involved you want to be with this.
Awesome. Yeah, thank you so much. So Yunna, I learned a lot. Now you went through your cancer journey without a physiatrist. What do if you had a physiatrist, what would be different about your journey, do you think?
Well, for me, because I had low anterior resection syndrome after my rectal cancer, I didn't really know, even being a physiatrist back then, I didn't really know how to deal with the bowel symptoms that I was having constantly. And it literally took a Reddit post from a friend to try doing tap water enema. But I feel like if I had Sean or a cancer rehabilitation specialist on board, I would have gotten there so much earlier, which would have helped me go back to work, enjoy my daily life with friends, like going out and eating at restaurants and things like that, because I couldn't do that at all until I landed on the proper bowel regimen. So I think it would have really, really changed my life significantly, or my suffering would have been much less too.
What struck me was kind of the complexity of cancer rehab. You've got all these different medicines with complications and radiation, plus with treating somebody with a stroke, you tend to see a steady recovery. And with cancer, it can be up and down. And they've got neuropathy now, and they've got new mets somewhere, and it's just very complex.
Yeah, and I love what he said, advocacy, 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 and also be prepared to care for the patient regardless of what symptoms they come in with, because I feel like that's common in physiatry. They have these diagnoses, but you don't know what the patient's overall function or condition is for each visit.
This has been The Summary, a podcast brought to you by Mary Free Bed, hosted by Dr. Yunna Sinskey. Like, comment, and subscribe wherever you get your podcast.